One of the issues was the forward planning to develop Bedford in the way that modern paediatrics should be delivered. And I think part of their problem was they were heavily reliant in the past on absolutely committed, totally dedicated consultants who gave their all for local children and who had one-to-one relationships with the children. They provided their level of experience to the local children. But behind them, things were changing. That sometimes you couldn't be a consultant who was an expert in a whole range of fields. And we have consultants here who looked after children's cancer, children's diabetes, children's long-term conditions, were there on duty day and night, who looked after the neonatal unit. Well, that type of experience isn't available anymore because the breadth of knowledge you need is so enormous. You needed to have a diverse consultant workforce, and that's the one thing that they didn't really have. And that was due to over-reliance on the existing workforce who seemed to be delivering a good service. But when they retired, and the two key people retired together at the end of last year, that started to come apart. And that is why Bedford ultimately ended up with this falling over. Because another aspect of consultant-provided service is teaching. You have to teach and supervise and mentor. It's an absolute commitment. It's part of the job. They could do that, but the demands made by increasing numbers of trainees with complex requirements was increasing beyond the capacity of the service here to deliver. And that's really where it all came apart. That had been a long time in the coming. People did see it evolving, but unfortunately things didn't change. So what we've done is we've reinvented Bedford in some respects as an innovative go-ahead unit that's looking at modern ways of delivering care in keeping with the most modern advice available from colleges. And the other thing that's quite interesting is the number of professional organisations, the regulatory authorities, that determine the standard of your service. So a CCG on its own cannot commission substandard services because it would be held responsible by the Care Quality Commission, who, as you know, are now doing many more visits. So in order to drive up service quality, you needed more people to deliver the wide variety of things that contribute to good medical care. It isn't just about looking after the patients at the front door. And by really demonstrating that Bedford was committed to that change, we seem to have turned around the tide on recruitment. No, because every consultant is supported by, and in turn supports, innovative nursing techniques, modern ways of providing care, quicker turnaround, decision-making that's not made. I'll give you an example. We used to see children admitted with tummy ache on a Friday who waited till Monday to see a surgeon to be told you had constipation. Is that a good use of services on an inpatient unit? It's just unnecessary. So we needed consultants at the forefront who can make those decisions, but they have to be supported by teams of nurses. We also have to train junior doctors in this way of working. And as I've said before, not everybody can do this. It's a different way of working. You also have to support colleagues in surgery. You have to support colleagues in anaesthetic, and in turn they support you. And there clearly is a need to support the patients who still come in through the emergency department, where they're seen by generally trained, experienced doctors, but in emergency medicine. And at the moment that's something that we haven't gone out to do immediately because we're building our service. Yes, emphatically, you do need a consultation, because I can't single-handedly bring about a change. It has to be bought into by everybody, and that's from the service users, the patients, the parents, the grandparents. Out of interest, when I used to do consultation meetings across Hertfordshire, the biggest group of people that I probably had trouble with were the grandparents. And that wasn't to do with their vested interest in their grandchildren, it was the issue of change from what they were used to. I'll give you an example. When I started in paediatrics, we had wards where we were festooned with drips. Every child had a drip up. I don't know why. Well, that's gone. We had children who spent 3 days in hospital being regraded after gastroenteritis. That's gone. And we had children in having joint replacement for rheumatological conditions. That's gone because of modern drug therapies. How do we modernise services to deliver that level of care? You have to change. So in terms of how do we get to that point, you consult with people, you express where you're seeing things from, and you listen to where they see things from. A service that is right for the people of Bedford, but also reflects the needs for children, how to deliver a modern paediatric service that reaches up to the highest quality of care that children should and their families should expect. And that may mean changes that are a little bit more challenging. We'll see. So if you want, what do patients deserve? They deserve the best possible care, but to deliver that might mean some challenging options. In respect of that, it's looking at where do you get the best expertise from for a so-called local service. You may have to go a bit further afield. I don't know. And one of the things we're hoping to do is every consultant recruited here is being encouraged to have an attachment to a specialist centre. That might be for the newborn. It might be for diabetes. It might be for cystic fibrosis. It might be for children's cancer care, children's epilepsy care. These are all, and the other big one is children's rheumatology care, children with problems in their joints. Now those attachments cannot be, you can't attach yourself to another local general hospital. They don't have the expertise either. But together with other local general hospitals, we can build up local expertise and have consultants who spend 1 or 2 days a month attending at a specialist unit and then bring those skills back. So children don't have to go down to the specialist unit every time. They can have some of their service provided locally. That's the model we'd like to work to. And that will enhance recruitment and retention because there's more job satisfaction then. You've got to look at the whole career of the staff that you have here, nursing and medical. Yes, I think you can. The question is, can you afford not to?